I'm Phil Beckett. I'm with Baylor College of Medicine in our IT group and Executive Director for Clinical Applications.
And I'm Jeff Steinbauer. I'm a family doctor, a professor of family and community medicine, and I'm the Chief Medical Information Officer for Baylor College of Medicine.
I think from my perspective, there's three things really driving that. Two are from the Healthcare Reform Act and the incentives for e-prescribing, the incentives for meaningful use, which includes the e-prescribing, and the adoption of electronic health records. And also, I think here in the Texas Medical Center, you've got a concentration of big organizations that are using electronic health records. So perhaps the adoption of those systems is higher here than maybe nationally.
Texas population is really concentrated in three areas: in the Dallas area, in the Houston area, and then over in the Austin, San Antonio area in the center of the state. And in at least two of those three areas, there's been a very rapid adoption of the electronic records. So as Phil says, I think just the fact that so many physicians now have access through their networks and through sponsoring institutions to electronic records, we're seeing a really rapid adoption of that. Plus, our experience here was that prior to meaningful use, the majority of our physicians, despite having e-prescribing available, were not e-prescribing. We started sending reports to our physicians in February of this year on how they were doing with meaningful use, that had very simple red bars and green bars. And once we started sending those reports, we started noticing a lot more people who were making green bars in prescribing. So I think meaningful use, I agree that meaningful use and the incentives through the American Reinvestment and Recovery Act have made a substantial difference.
From a technology perspective for us, that really wasn't available until we had electronic interface to Surescripts. We had electronic medical record. With that integration, we had that information available to us for benefit, for formularies, but we just didn't have the bandwidth to maintain it, to keep it up to date for all the payers. Through the interface with Surescripts, we now have that automatically. Again, with medication history, that just wasn't available to us except through patient history. Now we have a query that runs based on appointments every night and gives that full patient or medication history, at least from the PBMs. So it just wasn't available to us through a paper system in any realistic way.
So I can certainly speak to the feedback I get from patients, and pretty universally patients comment about how wonderful it is to realize that as I'm standing in the room hitting a few keystrokes on the computer, that their prescription has just been sent to the pharmacy. So I tell them it'll be waiting for you when you get there, and they think that's really terrific. It's very convenient for them. A lot of the patients who were maybe more savvy or more bold would finish the visit saying, "Will you have your nurse call in the prescriptions for me so I'll be waiting?" And it's always gratifying to me to say, well, she doesn't need to because I've already sent them. I think that that's something that the patients really like. It's a direct benefit that they can see. As far as patient safety is concerned, I think just the fact that we're using an electronic record, and it reminds me if I'm getting ready to write something that cross-reacts with a sulfa allergy or that interacts with medication that the patient is taking, that's handy. I've not heard physicians actually say that they like it. On the other hand, I haven't heard physicians complain about it either, and so the latter is probably a pretty good marker of the fact that it's helpful.